Charcot-Marie-Tooth disease, also known as CMT, the neuropathy, hereditary, motor, and sensory. Neuropathy and peroneal muscular atrophy is a genetic and heterogeneous group of inherited disorders of the peripheral nervous system caused by a progressive loss of muscle tissue and touch sensation across different parts of the body. CMT was previously classified as a subtype for muscular dystrophy disease named after three different people who classically described it: Jean Martin Charcot, Pierre Marie, and Howard Henry Tooth. CMT can be classified as a result of genetic mutations and based on the affected gene. Clinical types are CMT1, CMT2, CMT3, CMT4, CMT5, CMT6, CMTRI, and CMTX. And here's the categories. CMT1 is a demyelinating type which impairs the nerve conduction velocity. CMT1 affects about 30% of CMT patients. CMT is an axonal type which affects the lower extremities more than the upper extremities. The symptoms are less severe than in CMT1. The nerve conduction velocity is not affected here. CMT2 affects about 20 to 40% of the CMT patients. CMT3, also known as the Dejerine-Zotis disease, is the rarest and does not impair the nerve conduction velocity. CMT4 is a spinal type. CMT5 is a pyramidal type. CMTDI is a dominant intermediate type. CMTRI is a recessive type. CMTX is an X-linked type. CMTX affects about 10 to 20% of CMT patients. The genetic cause for CMT1 is caused by the mutations from the genes PMP22, MPZ, LITAF, EGR2, and NEFL. Genetic cause for CMT2 is caused by the alterations from genes MFN2 and rarely KIF1B, RAB7A, LMNA, TRPV4, BSCL2, and GARS. NEFL, HSPV1, MPZ, GDAP1, and HSPV8. Genetic cause for CMT3 is a duplication of a large region on the arm of chromosome 17 that includes the gene PMP22. Genetic cause for CMT4 is caused by the mutations from the genes GDAP1, MTMR2, SBF2, SH3TC2, NVRG1, EGR2, PRX, FGD4, and FIG4. The genetic cause for CMTDI and CMTRI is caused by an altered gene DNM2 or YRS. Genetic cause for CMTX is caused by the mutations from the genes GJB1 and PRPS1. CMT1, usually CMT2, CMTDI, and CMTRI are inherited in an autosomal dominant pattern. This is when one copy of the altered gene in each cell is enough to cause the disorder CMT4, and a few forms of CMT2 are inherited in an autosomal recessive pattern. This is when both copies of the gene in each cell have mutations. Usually, the parents of an individual with an autosomal recessive condition each carry one copy of the mutated gene, but does not show signs and symptoms of this. CMTX is inherited in an X-linked dominant pattern. This is when the mutated gene is on the X chromosome. It is dominant if one copy of the altered gene is enough to cause the condition. The metabolic cause of CMT is caused by the mutations that cause defects in the neuronal proteins. The nerve signals are escorted by an axon with myelin sheath wrapped around it. Most of the mutations in CMT affect the myelin sheath, but some affect the axon. The most common cause of CMT is the duplication of large region on the short arm of chromosome 17 that includes the gene PMP22. Some mutations affect the gene MFN2, which is the mitochondrial protein. The cells have separate sets of genes in their mitochondria. In nerve cells, the mitochondria travel down the long axons, and some forms of CMT, mutated MFN2 genes, cause the mitochondria to form large clots which can't travel down the axon to the synapses. Therefore, the synapses will not function. CMT is divided into the primary demyelating neuropathies. The Schwann cell, which creates the myelin sheath, wraps its plasma membrane around the axon in a structure. Neurons, Schwann cells, and fibroblasts work together to create a working nerve. Schwann cells and neurons exchange molecular signals, the differences in keeping it living. The molecular signals delay CMT. Demyelating Schwann cells causes abnormal axon structure function, such as axon degeneration, or actually cause the axons to not work the right way. The myelin sheath lets the cells to carry out signals faster. When the myelin sheath is damaged, the nerve signals are slower. When the axon is damaged, the compound muscle action potential is reduced. Symptoms of CMT usually begin in late childhood or late adulthood. Some people will not have any symptoms until their early 30s or 40s. These symptoms and progression can vary with the disease. Breathing, hearing, vision, and neck and shoulder muscles can be affected. Scoliosis, where the hip is abnormal curving of the spine, can occur. Hip sockets can be contorted. Gastrointestinal problems such as chewing, swallowing, and speaking can be part of CMT too. The first symptom early on in the disease is a foot dropping, causing a claw toe where the toes are always curled. The lack of muscle tissue in the lower parts of the leg may give the appearance of a stork leg. You may become weak in the hands and forearms later in life as the disease progresses. You can also experience a loss of touch sensation in the feet, ankles, legs, hands, wrists, and arms. High arched feet can occur. And that is a sign of Charcot-Marie-Tooth. Life as we know it can be damaged, but the pain nerves are not. Overuse of an affected body part can start numbness, spasms, cramps. CMT can be diagnosed several ways from the symptoms. The measurement of the speed of the nerve impulses used by an electromyography, the biopsy of the nerve, and through the DNA testing. Not all of the genetic markers for CMT are known, but DNA testing can give a definite diagnosis. Patients showing the signs or symptoms of CMT will be referred to physicians specializing in neurology or rehabilitation medicine. CMT is currently incurable. Clinical trials were ran and high doses of vitamin C in treating humans with CMT1 have been conducted, but not for children. Patients with the CMT disease need to maintain what movement, muscle strength, and flexibility they have. Physical therapy is recommended. A physiotherapist should design exercise programs to help maintain their strength and flexibility. Braces can help control the foot drop and balance for patients.